Hey, Andrew. Dana might be a few minutes late, so I'm going to do the introductions and get things started. Are you okay sharing your screen? Are you able to hear me? Good morning, everyone. We'll give everyone just a few more minutes to log on. Thank you for joining. Hope you grabbed some lunch and we'll get started right at noon. All right, it's 12:01, so we'll go ahead and get started. My name is Amber Kavan with the Nebraska Hospital Association, working on the Quick project with Dana and Margaret. So thank you all for joining today for our 5th session of our sepsis learning cohort. We're excited to wrap things up here in the next couple weeks. So if you guys wouldn't mind just chatting in your name, your facility, who's joining you today, that'd be great. Also, if you wouldn't mind chatting in some of the sepsis projects or any quality processes that have changed or have been revised with this cohort, please share that. Just a couple housekeeping items. If you wouldn't mind muting your line, unless you want to speak up, you definitely can unmute yourself and have an open discussion with the group. But with that, I will introduce our speaker, Andrew McCarty. He is the sepsis and stroke coordinator at Mary Lanning. So I will pass the baton over to you, Andrew. Thanks, everyone. Andrew, if you're talking, we can't hear you.
Hey, Amber, can you hear me?
Yeah, I can hear you now. Can you hear me? Can everyone hear me okay?
I can hear you.
Thanks, Denise.
Amber, can you hear me?
Yeah, can you hear us?
Oh, perfect. Now I can. I don't know what was going on.
Okay, great. We're ready to roll when you are.
Sounds good. Let me do that. Okay. All right. So sorry I didn't hear everybody right at the beginning there or that introduction, but we'll get started. So my name's Andrew McCarty. I'm a registered nurse at Mary Lanning here in Hastings. I've been the sepsis program coordinator here for 4 years now, going into 5, but 4 years. And I'm also our stroke program coordinator. So both of my positions fall underneath our quality department. Just of note there, the Lean Six Sigma Greenbelt, for those that may not be aware of that, or what that is, our quality department about 5 or 6 years ago started these courses for employees here at Mary Lanning to learn about and understand process improvement and what that looks like. So I just wanted to highlight that since this talk today is about process improvement, strategies, some of the things we do here, maybe give you guys some ideas that you could take back to your own organizations and implement. So I just wanted to highlight that. Just briefly about Mary Lanning Healthcare, kind of where we're located and who we serve. We're in South Central Nebraska. The reason I wanted to provide a little bit of this background information, because I know everyone comes from, different communities and, different parts of the state, different areas. So I just wanted to provide a little bit of background about the community that we're in, the counties we serve, critical access hospitals in our area, and then our EMS squad. So we primarily have patients transported to our emergency department by Hastings Fire and Rescue. They're our ACLS squad. We do have a number of rural squads as well that will meet sometimes with our ACLS squads to bring patients in. But I like to mention that because similar to sepsis, and similar to STEMI, pre-hospital notification, pre-hospital care is really important. So if you're tapped into those EMS squads and can provide some additional education to them, that's always very helpful. I've been giving stroke and sepsis talks to our EMS providers for a number of years now, and I've just kind of combined the two topics. I usually spend a portion on stroke and a portion on sepsis. So just wanted to make mention of that as well. So while we're all here to talk about sepsis, we know it's prevalent. We know that, you can kind of boil it down to that graphic there. Those are the most common infections leading to sepsis. At our facility, we see at least as far as the final coding diagnosis goes, we see anywhere between 30 to 40 sepsis, severe sepsis, or septic shock patients at our facility here. And I'll give you some screenshots of how I track some of the information on the back end as well. To give you an idea, I presented a couple of these slides for those of you that were on a few weeks back for my last presentation. Some of this stuff, a little bit of it's repeat, but for those of you that are new, I just wanted to just re-highlight sort of our timeline. So we do have a formal sepsis program here at Mary Lanning. It was about 10 years ago, a little over 10 years ago, that clinical practice guidelines for sepsis were developed, an inpatient screening tool. At that point in time, a lot of stuff was being done on paper. Order sets were on paper. And then my position was actually created in 2016. There was one previous coordinator prior to myself. So they were in the position for a year. When they left the position and it was available, I was just approached because the majority of what I was doing with stroke seemed to fit really well with process improvement that we could be doing with sepsis. So that's how I ended up in my position. And then 2017, so we transitioned to Epic. That's our EHR here, which is very nice. I know smaller facilities may not have access to, a med record like that, but there are some things that you can do within your own EHRs, or even just using paper, that I think could really improve your processes. So, and just to highlight the images that I have there, so we have improved over the course of time with our sepsis program, so much that in 2020 we were awarded these specific quality awards, and leading into 2021 we were actually awarded a 5-star CMS rating. Some of that was due to our decreases in sepsis mortality over the time frame from 2015 to 2018. So what I'm going to be talking about today is reviewing data, collecting data, mapping your process, and then how to really put together a process improvement plan for your team. So the first thing you're going to want to do is map your current process. And for starters, if you are not familiar with what your process is or what it should be, maybe you have a very loose process right now or no process at all, you really want to interview people that are immediately involved in that process. So frontline staff, nursing staff, providers, if it's pharmacists, lab personnel, whoever's involved in your current process or a process that you want in place, you need to be discussing with those people and getting their input. Another helpful thing is to just observe your process in real time. So, going down to the emergency department when a sepsis patient is in your emergency department to see how it all works. Take notes, be very detailed with your, the responses that people are giving you, or observations that you're noticing. And then really look to see, after you've had a chance to collect that information, are there steps that are being duplicated by different people that are involved? That tends to be, sometimes that can be due to just a lack in communication with the other departments. There might be things that are happening that are being done that people aren't aware that those departments are taking care of those steps. So once you have all of that information at hand, by interviewing staff, by observing the process, and what I think is really helpful is using some sticky notes, is to create your own process map. And this looks a little busy, I know, because this was before we cleaned up some things, but this was just done using Microsoft Visio, which is a Microsoft product, but the exact same thing that we did or that I did by putting this information into what are called swim lanes, that you can do a similar process, or you can do a similar setup of this by just finding some blank wall space, writing down process steps on sticky notes, and then tagging those to specific departments that are involved. So that's essentially what this swim lane process map is. Those lanes that, or those rows that go across, you can see there, emergency department nurse, emergency department provider, pharmacist, hospitalist, and then our fourth floor nurse. Our fourth floor here is where our ICU and PCU is located. So when I was initially trying to figure out if we in fact had duplicate steps, if there were redundancies, and just to try and put my finger on where some of our biggest hangups were, this is what I did. I started from square one by watching the process, by interviewing people, and then creating a process map, and then assigning those different steps to the people who were completing those parts of the process. So if you don't have access to Microsoft Visio, that's not a big deal. Like I said, you can use sticky notes and some blank wall space to create something like this. So after you've put together your process map, you've interviewed people, you feel like you have a handle on how it's supposed to look, identify where in your process that things might be slow, clunky, inefficient. If you're collecting data, or when you start collecting data, you can really boil it down to what are those pieces that are really delaying, whether it's antibiotics or it's lab results, ordering, even just simply identifying that the person's met sepsis criteria, whatever it is. Once you identify those slow, clunky, or inefficient steps, you can add that information into your process map as well. So you could start adding in, let's say one of these steps is, time to order. Well, you could include that information on your process map. You could create another sticky note to put on the wall next to that specific step, if you're mapping it out that way. So once you have the information, you want to identify where you might have some hangups. I have Pareto charts listed there. I'll kind of show you what that is. It sounds kind of complicated, but it's essentially just a visual way of representing where your largest sources of error might be. And then benchmarking. So if you have access to, data or information from other facilities across the state, use somebody that's, or communicate or contact somebody who is doing a really good job with their processes, so that you're able to compare yourself to other people. Or, initially you might have to just, internally benchmark, set a goal for yourself. Whether that's, I have some examples there, door to lab order. If your goal is to have those orders in within, let's say 30 minutes of patient arrival, there's your benchmark, there's your goal, and then collect data, and over a period of time, see if you're actually, meeting that goal. As far as data collection goes, and the processes tracking and reporting that goes along with that, you're going to want to decide what you want to monitor. So I'll just flip back here really quick. So those are some examples. So door to lab order, antibiotic order to administration. Once they meet initial hypotension criteria, how long did it take to receive a fluid bolus? For smaller facilities, your door in, door out time. Set a goal for that, and then track your process over time and some of these little pieces to see if in fact, you're able to meet your transfer out time. So decide what you want to monitor, design tools for how to capture that information. We used to use paper forms here. We don't anymore. I enter a lot of stuff into Microsoft Excel and keep a registry that I have a screenshot of. I'll show you. So design how you want to monitor, decide how you want to monitor, design the tools to capture the information, and then try and standardize the data collection so that anyone can enter the data in. Now, you may be, people on the call, you may be, the one person that's going to be doing it. okay, that's fine, that's great. If you're the only person that's going to be collecting this information, then that makes it pretty easy. But if you're relying on, specific forms or maybe spreadsheets that, other people are entering information into or writing information on, then you're going to want to find a way to really drill down on the specific information that needs to be collected, how it needs to be collected and entered and written down, so that everybody's doing it the same way every single time. It makes for an easier way to report out your data. It makes it easier to then communicate things back to frontline staff. And then you're going to want to decide how often you want to report out the information. So we do when I come in first thing in the morning, I send out a daily dashboard that essentially lists off, what patients we have currently, did we or did we not meet specific steps of the sepsis measure, and if we didn't, why. So I get here earlier than most in the morning to do a fairly high level just overview of patients that have met criteria that are in the hospital, to then send that information out to our daily safety huddle. There's a morning huddle here that all managers and directors attend. So if that's something that your facility is able to do, where you report it out daily, maybe you don't have that many sepsis patients you see on a weekly basis, you want to report things out monthly or quarterly, it's kind of whatever you and your team decide to do. And then you need to decide how that information is going to be communicated back to the frontline staff. So, is it going to be in graphs and charts? I've found that although a lot of my strengths are very analytical and math and science driven, there are plenty of people that, may struggle with charts and graphs and interpreting them and understanding them. So trying to find the best way to relay that information back to people that are the process owners in those departments, in those areas, so that they can then follow up with their own staff members. So this is a screenshot. It's a lot of information, I know, but this is just a screenshot that I took of part of our sepsis registry. I've color coded it in a way that helps me organize some things. I believe that Dana sent along, after my last presentation last month, I think she had sent along to those that were on, she emailed out a blank registry and a few other things. But for those of you that weren't on the call last time, this is, like I said, a screenshot of the sepsis registry that I keep. So information, obviously some basic stuff, when the patient arrived, time, were they an ED patient or not, when they actually met criteria. So this is like when I come in and do some high level abstraction first thing in the morning, I try and nail down really quick, when the person met severe sepsis criteria, and then really do like a chart abstraction as if this was going to be submitted the same day, back to CMS or whatever, that I take down the times of when things were collected or ordered, administered, whether or not we met the measure. If we didn't meet the measure, why didn't we meet the measure? And so this is just concurrent monitoring that I do. It helps me report things out daily. But if you're not comfortable with using Excel, which I definitely was not before stepping into my current positions, there are plenty of resources available online. I've looked up YouTube videos on how to create certain graphs and do certain things with Excel that I didn't even know were available. So not saying you have to use something exactly like this. I've found it very helpful. You'll just have to kind of decide for you and your organization what's the most helpful. And especially from a time standpoint, are you going to have enough time to maybe spend collecting and inputting all this information? Or do you really just need to focus on a couple areas that you really struggle with? This is really, this collection of information that we're getting, that I'm doing on a very regular basis, just allows us to look at all those incremental pieces though. So maybe after you assess your process and you determine, there's one or two specific things you want to focus on, maybe you just collect that information. It's kind of just up to you. Communicating data back. So on the left here, this is just a screenshot. I took out the patient information on here, but this is just a screenshot of what I send to our daily safety huddle. And those are just the specific pieces of the measure that if we meet those within the specific timeframes, we know we'll meet the measure. So it's essentially a way to communicate, did we or did we not meet the measure for this patient? And then if we didn't, why didn't we do it? So it's a very, easy to understand, check mark, thumbs down. If it's time sensitive, it works out pretty well for our facility. These other screenshots here, the top one's just a graph of process data that from this registry here, I'm able to, put together a graph that shows, what percentage of the time are we meeting this specific step in the process. So as you can tell, and it's not, we're not alone in this, but, we still struggle with fluid bolus administration for patients that present with initial hypotension criteria. I have an example on the back end, one of the last couple slides, and then just a couple things we've done to address that. But yeah, we struggle with fluids just like other facilities struggle with fluids, whether that's initial hypotension or if they've met shock. So we know that's an issue for us, and we've taken some steps to address that. And then the lower right screenshot is just the quarterly information of times. So the top one is how often are we meeting those steps? And then the bottom right one is the timeframes for those steps and how long on average is it taking us to do those things. I have the antibiotics administered row highlighted because we have seen delays in our antibiotic administration over time. I still haven't really figured out why. But again, along with the fluids, that's just one other area we know is a delay for us and that we can address going forward. I don't have any good answers right now, but I'm hoping something will come up. So where are the deficiencies? Like I said, Pareto charts seem a little confusing to some people, but essentially what this is, it's a graphical representation of percentages. So if you look at the fluids there, and this is for us, this is our information. So in Q1 through Q3, for the patients that were true sepsis fallouts for the core measure, 14 of those patients didn't have fluids administered. So that number 14, that's half of the 28 times we did not meet the measure. If you go across from left to right, you'll see like 71.4%. So the 14 fluids, patients that didn't have fluids, plus the 6 that didn't have antibiotics, so that's 20. We know we have 28 total fallouts. So it's just 20 divided by 28, 71.4%. So it can get a little tricky as far as like putting these together. I mean, once you figure it out, it's pretty easy to do, but this just provides that visual for, a manager, a director, administrator to just show that, yeah, okay, this is where we struggle in our process. We know that if we were to correct our fluid problem and our antibiotic problem, that's the vast majority of our issues when it comes to meeting the sepsis measure. And so it's just a good visualization. The third bullet point I have listed there just states, another way to track your process deficiencies is to set time goals. So whether or not, I had mentioned, you can break down your process however you want to, but if there are specific time goals you would like to meet for ordering things, administering things, getting a patient out of your emergency department, essentially that's just kind of a yes, no, did you meet your goal for 30 minutes or not? You can create a Pareto chart in the same way. I think I have an example here also. Yep. So this is just, these are random numbers I put together using using specific things that we track. You know, in an ideal state, some of these goals might actually be quite a bit less, but so this is just an example. You know, if you were to do this at your facility, so I just have there, it's unclear where your process deficiencies are, so you decide to evaluate process steps for the last 100 sepsis patients at your facility. Maybe it's the past 20. I don't know how busy some of your facilities are with sepsis patients, but you know, pick an arbitrary number for your facility, 20, 25, look at the last 2 months, whatever it is. And then I just have there, your goal is to count whether or not each patient met the specific step in your process. So the goal is for antibiotics in this example to be administered or ordered in less than 60 minutes. So for patients that had it ordered greater than 60 minutes, there was 93 of those. Again, I just kind of picked arbitrary numbers here. And so of those patients, and you can kind of look on the graph or on the screenshot of the cells to the lower right there too, but of those 100 patients, so 67 of those patients had lab results that were greater than 45 minutes. 25 of them had antibiotics administered in greater than 90 minutes, and sepsis orders placed greater than 15 minutes. So this is just, again, to sort of highlight or help you visualize where your largest areas of deficiencies are. Now, without making this chart, you could merely just have the lower right hand, you know, goal not met 93 times. In this particular example, there were 205 times where the goal wasn't met. So you could just do the simple math, 93 divided by 205. So 45% of the time, it's related to antibiotics. If you lump in the lab results with it, 78% of the time, you're having issues with labs and antibiotics. So you could just have the numbers and report it out that way to, again, managers, directors, administration, whatever. This is just a way to graph it, to visual, so they have a visual of, okay, I see exactly where our problems are. And if we solve these problems, then, you know, we're going to have very few things as far as like maybe a sepsis measure that we fall out on. We're going to have very few times where we have a delay to transfer. So again, it's all in kind of your comfort level. One with data collection, maybe your comfort level with some Excel stuff. But also, again, you know, identify where your areas are in whatever fashion you're most comfortable with, and then address those specific things. You don't have to necessarily track every single thing that I do or that we're doing. Just use kind of what's best for your facility. This is another way, very simple way to also kind of group or categorize where some of your issues are. So you observe the process, you've interviewed staff, you have a process map, you're collecting some data. You know, maybe you and your team get together to brainstorm exactly like what you want to focus on. I think that would be very helpful for you and your team. So a graph like this kind of, again, provides that visual to people, you know, where you want to spend your time. So the lower left-hand quadrant of this chart is easy to implement and the payoff is low. So it's really easy to do. You might not get a lot of bang for your buck or return on investment, but it's really easy to do. So you could focus on those things. The top left would be ideas, steps that are very easy to implement and very high payoff. So when you're talking about like low hanging fruit, you know, that's the cliche phrase, but you know, ideas that would be very easy to address, you want to stick to the left-hand side of this particular chart. When you go to the right-hand side of the chart, things get more difficult and they're high payoff in that top right-hand quadrant. So yeah, they're important, but it's going to take some time. So those might be some of your longer term goals that you plan on addressing, things that, can't be solved, right away, but it's on your list of things to do for the next quarter, the next 6 months, whatever it is. You just know that it's going to take more of your time. It's important, but it will involve an investment on your part. And then the lower right, I just have don't bother there, because if it's very difficult to implement and you have a low payoff, then don't bother don't bang your head against a wall with those things. So again, this is just a easy way. You can do this on a whiteboard. You could do this just on a wall with sticky notes, but this is just a way to group and categorize solutions for your specific process issues that you're dealing with at your facility. And then I just have a couple slides on just process improvement strategies. Some people may be familiar with this, the DMAIC process. It's just a structured problem solving methodology used in business. This goes back to when I was saying the Lean Six Sigma certification that I had. Our quality department started having these courses. We had a black belt instructor come in, and we all kind of selected different projects across the facility that we could work on. And so within that whole course, we were taught these specific steps that need to be addressed as you're working your way through process improvement initiatives. So the D just stands for define, meaning, you have a team together, you reach an agreement on, what you want to address. So the scope, the goals that you want to accomplish. And then if there are, performance targets or, financial savings that could be seen from doing things a little bit quicker, being more efficient with your process. The M is for measure. So that goes back to getting an idea of what your process is, and then collecting data on that process, and then analyzing it, with a Pareto chart, with however you want to graph things. But you need to have a way to, take that data and then really look into those causes, those root causes of like why you're having so many issues with this particular step. And then the I's for the improve phase. So you want to, implement whatever it is that you think will address that specific issue, or maybe there's a couple things, is implementing it and then monitoring that over a period of time to see if that actually, what you did had an impact on that specific piece of the process and the process as a whole. And then the control phase is just passing it off to the process owner. So I know if there are other like sepsis coordinator people on the call, or other coordinators on the call just in general, I know one thing that can oftentimes be frustrating in like a coordinator type position is you're not really in charge of anybody. So I'm not, the manager or director over our ICU, PCU staff or emergency department or lab, but you're the person that works alongside everybody, collecting this information and providing it back to them in a way they can understand, and help them with their process improvement, strategies. You're not the one that's ultimately, in control of the situation. It's the process owners that, really have to make sure that those steps are then, taken and followed. And if they're not followed, following up with staff. So that's kind of an important piece too, is the handoff and making sure that people understand what their roles and responsibilities are after you've implemented this new change. The other strategy that might be more familiar to people though is this PDCA. So plan, do, check, act. In the planning phase of process improvement, you're going to want to put a team together for sepsis specifically. That's probably pharmacy, somebody from lab, somebody from the ED. I said in my last talk that it's really important to have administrative support if you're going to be, you know, creating plans and implementing those plans. It's really important to have some administrative support. And having administrative support also involves maybe collecting some data and information first to then present it to them and say, okay, I think we need to, you know, address these specific issues, or this is why this is an issue. So make sure you have the right team in place, establish goals, objectives, what you're going to be collecting, and then what ideas you might want to implement. And then the do phase, you execute the plan, test the small changes that you make, you know, over a period of time, 1 to 3 months or something. You know, see if those changes you made really had an effect on the, you know, the times that you're collecting, or the length of stay that these patients are at your facility, or the time it takes to transfer them out, whatever it is. And then, yeah, that kind of leads into the check, and then act or adjust, reestablish a baseline for the next cycle. So it's just a constant kind of resetting benchmarks, resetting goals, doing it over again. But it's, yeah, just a quality control strategy that can be used on a single issue or larger processes. It's pretty easy to implement. I put that there with a caveat, though. It's easy to implement if you have the right people in place from the get-go. So making sure you have the right team members in place to have the initial conversations is really important. I can't stress that enough, because I even ran into issues when I was going through my Greenbelt class with the project that I was assigned to, that we just kind of struggled from the onset because we didn't have the right people in place at the beginning. So that's important. Get a team together that has the right people on it. And then this is just what we've done here. I mentioned this earlier with the fluid administration. We know a majority of our sepsis core measures are related to fluid bolus and antibiotic administration. I know that because we track it daily. I report this stuff out monthly and quarterly. It's been kind of a persistent issue. And so I just have there, after abstracting the fallouts, following items were noted. So 1, providers were not utilizing the order sets as designed. I noticed that incremental bolus orders are placed instead of a single order for the total amount. Depending on your EHR and how, or paper order sets or whatever you use at your facility, you know, there is a tendency for some providers to order, let's say like a 500 bolus, see how the patient responds, order another 500 bolus, see how they respond. That really messes up your timing, depending on when severe sepsis or septic shock criteria was met. So, you know, that's one area that we can address with them. And like I have there, we also received feedback from providers on the layout of the order set for fluids and antibiotics. We were able to minimize a lot of things and clean the order set up. It was something that was very minor, but in my mind was very minor, but it was something we heard from quite a few of them. So that was one of those like easy to implement, not necessarily like high payoff, but very easy to implement. The second thing, their providers were and are generally conservative with fluids for patients who may not tolerate fluids as well. Your CHF, your chronic kidney disease patients. Total fluid bolus was not being administered. So one of the only exclusion criteria for sepsis patients who meet the fluid bolus requirement is patient family refusal. And so that kind of leads into the third point there. Providers were not documenting detailed conversations with patients regarding fluid resuscitation, the benefits and complications. And then I just have listed there exclusion criteria for the SEP1 measure includes patient family refusal. So, you know, in an ideal world with every single patient that comes into the emergency department, yes, our providers should be having the conversations with patients about the risks and benefits of different types of treatment. You know, if it's not being documented, you know, then technically it didn't happen in the eyes of a reviewer or someone in my position who's abstracting charts. So with that, you know, we've really encouraged them to have those conversations, to document that appropriately. And then we even went one step further, which was within our EHR and Epic. If some of you are on Epic, we're able to create what's called a smart phrase. It's just a standardized phrase that they can utilize to document. Again, this goes back to like the ease of implementation. I mean, there's an education component to it, but if it's something your providers are aware of, they know that if they document this, they have their clinical judgment, obviously, but if they don't think that the fluids are warranted, they have the conversation with the patient, they can certainly use this phrase that we've created. And then we know that that person's going to be excluded when we abstract them for those patients that have been selected for the measure. So that was kind of a lot. I can be a little wordy, but the next steps that you could do at your facility, I just have brainstorm, really meet with the people that are intimately involved in your processes, whether that's with lab or pharmacy or your emergency department, and talk to those people and see, gather some opinions. Like I had mentioned, when you create a process map, you want to observe the process yourself. So identify what steps in your process are the most time consuming or inefficient. After you've had a chance to interview people, put some stuff on sticky notes or, doing something electronically, create your map. And then also design your ideal state process map. That's not something I attached onto this because I couldn't find it, but the initial swim lane process map that I put on there, that had a lot of steps. There were a lot of lines going everywhere. It looked really busy. So when you collect the information from your staff and you observe your process and you list out all those different steps that people are doing, but see how you can whittle that down to what would be considered an ideal state if you eliminated the redundancies, that goals were being met in the different timeframes that you set, to provide that and say, this is something we're working towards, that here's where we're at, here's our current process, really busy, kind of clunky, here's where we want to be. And that allows you to at least have some goals that you can set to get to that ideal state. And then tackle, like I said, low hanging fruit, things easy to implement, and then, start to create a PDCA, whether it's addressing the process as a whole. I would take small bites first and address something simple, but start with something that's very manageable, that you and your team think is would be the easy to implement and high payoff, or easy to implement and low payoff, whatever it is, make it easy. But begin creating like a PDCA for your team and see how that goes. I think that might be everything I have. I tend to talk quickly, so I apologize. I left about 15 minutes for if anybody has questions, or Amber, if you have questions, I guess, or anything you want to interject.
Well, that was great, Andrew. Thank you. Yeah, please, if you have a question, unmute yourself. I'd be curious to hear what everyone's working on and where you're at in the process.
I should have shown my face at the beginning. This is what I look like. So
thanks, Andrew, for sharing. We're going to be going to Cerner, so we're going to kind of wait till we go live to start some of our gathering. We do a lot of stuff manually, but really want to look at our order sets and percentage of order sets utilized. Right now, it's difficult in our current EMR.
yeah, we and that's kind of, somebody just asked me about that the other day with utilization of our order set, depending on your EHR, and I'm sure Cerner, you can run plenty of reports just like Epic, but we can technically run like how frequently our ED providers are actually utilizing the sepsis order set. The tricky thing is, they could open the order set, place like henpeck a couple orders out of it. And then when you run a report, it'll show that that order set's been used, although they really haven't utilized it like as intended. So that gets a little tricky, but I'm sure like I said, I'm sure there are ways in Cerner that you could track that information. That's been a little bit of the challenge with the fluid bolus specifically, because, you know, a provider can go through and enter all the initial orders using the sepsis order set, hop out of the order set, and then just place, you know, individual orders for fluids and antibiotics and things, instead of going back into the order set to then place those orders using the order set, which calculates, you know, the full bolus for them, and then has all of the antibiotics grouped accordingly. So
That's a great point.
kind of need to go back to the drawing board with some of them to provide that education piece, because if they are just henpecking through the orders, then it's kind of like, well, why do we have the order set then, you know?
We do have a question in the chat, Andrew. Does the timer start when the patient is admitted to the ED or when the sepsis order set is initiated?
So what I track, and that's what's a little different as far as like the data piece goes, like sepsis and stroke. With stroke, we're looking at, you know, patient arrival to, you know, CT and CT results and telestroke involvement and door to needle time, all that stuff. With sepsis, it can be a little challenging. You know, we're looking at, I'm tracking a couple things in tandem, which is when the patient arrives, yes, how long does that take? I want to get a pretty big picture idea of from when the patient arrives, you know, how long is it taking for our providers to place an order for initial labs, or, you know, so for our lactic acid, for our blood cultures, for our antibiotics. But I'm also looking at a couple things, you know, within, like, once they meet sepsis criteria, how long is that taking to then place orders for antibiotics? Because as maybe some of you are a little more familiar with when it comes to like the abstraction piece, is the timing does not happen like in a linear fashion. So it's not like, you know, patient arrives, criteria is met, we get blood cultures. I mean, I wish it happened that way every single time, because it'd make data collection a lot easier, but it does get a little bit challenging. So I kind of do a couple different things. I think for starters, if you're not tracking anything, I would just start from the bare bones of use like time 0, patient arrives, and then, you know, they may not arrive with severe sepsis criteria being met, but they might meet it within, you know, 45 minutes. Well, at your facility, you know, what is your general process for like when labs are being ordered on patients? You know, is it common for labs to be ordered, you know, within 30 or 45 minutes, whatever that is? So I'd maybe just get a pretty high level on some basic pieces of data, starting from time 0 of when the patient arrived would probably be a good place to start.
Another question that came in is, are you guys trending your lactic acid with your order sets?
I think we had this, I don't remember if we had this question come up last time, or maybe I just mentioned it, but so the lactic acid orders placed with the sepsis order set, if the lactic acid result comes back and it's greater than, if it's 2 or greater, then within, kind of built within Orchard as the lab platform, I guess, for Epic, like built within Orchard, once that's resulted 2 or greater, then an order is automatically placed for a repeat lactic acid. If your facility doesn't have access to an EHR like that, you know, you may just have to look and see if that responsibility, you know, can be placed on whatever lab tech, and that communication piece back to the provider to say, you know, the lactic acid's greater than 2, the person is meeting criteria right now for severe sepsis or whatever, you probably need to order the repeat one, within 6 hours. Ours is automatic. It wasn't like that before, but once we transitioned to Epic, we were able to build that in, which is pretty nice. Does that answer the question?
I think you nailed it. Thank you,
Okay.
Andrew.
Okay.
I do have a question, just talking to different facilities across the state.
Yeah.
I know we are all kind of living and breathing COVID, and we have been for a long time. But what I'm hearing is patients come in, they're super sick with COVID, and we know all of these COVID patients are very sick, but they have sepsis as well. So a lot of that is being overlooked because they're so focused on COVID. So I was just wondering if you had any suggestions, or if you guys are seeing that too.
We are seeing it very similar, and with some of the my understanding is with some of the new literature coming out and kind of how clinically we're treating some of these like sick COVID patients is, yeah, you don't, from a fluid standpoint, which is what we struggle with, like you don't want to, they're really conservative with fluids for those particular patients. The nice part from a data standpoint, so not like the clinical aspect of it, but the nice part from the data standpoint is that if COVID is anywhere in their discharge diagnosis, I think their DRG diagnosis, that they drop off on the back end as far as the registry goes. So I don't include those patients in with our data, with our times and our pieces of the measure that we're tracking. So from that standpoint, that's nice because they don't factor into our overall sepsis data and what we're reporting out. From the clinical standpoint, though, it is challenging when they do meet specific criteria, and they obviously, they can become septic, they can have, bilateral pneumonia, and they can be septic and also have COVID. And it's walking kind of a fine line of, being really aggressive with your sepsis treatment, while at the same time, not wanting to overload these patients with fluids unnecessarily. So it's kind of tricky. But from the data standpoint, though, it does make it a little bit easier because I don't even follow those patients anymore. I used to, just to make sure that on the back end, when they were all coded out, to make sure I wasn't missing anything. But anymore, I just, we have a patient that comes into the ED and, they pop positive for COVID, then I don't even bother tracking them from that point.
Sorry, there's another one in the chat, but I lost my chat. There it goes.
Oh.
Okay, so they've implemented the repeat lactic based on result. Badge buddies for new fluid documentation as of July of 21. Outliers to providers, quarterly QAPI, health stream education for RNs with a tool, contest, and meaningful data. Appreciate all. Okay, that was just input. Sorry, not a question as I read it.
Oh.
All right, any other questions anybody has?
And I think I could put it back up, or you could email it out, Dana. But I guess one last thing I'll say is, if anybody has any questions, I'm not saying I have all the answers. I think I've been doing it for long enough now, and my close working relationship with our quality department and our quality analysts and stuff, I think I understand a number of angles about sepsis. And so if people do have questions or need assistance with certain things, I'd definitely be willing to help you out, if you just want to shoot me an email or whatever. So.
Well, thank you. That's very gracious of you. All right. Well, I don't hear any other questions right now. I will make sure everybody has Andrew's email address. If you don't, it is on the slides, which will be on the website as well. So we can get to it one way or the other. But thank you everybody for joining us, and thank you, Andrew, for taking the time. I really appreciate it. And holler at me if you have questions, or reach out to Andrew and we'll get you connected. So everybody have a good rest of the day.
All right. Thanks, Dana.
Thanks. See you
Thanks,
later.
everyone.